Shaping the Future of Hepatology, the title I really like a lot because it's all the pediatrics that is going to be here. So we don't have many adults, but for the benefit, we know that liver plays a very central role in the synthesis, degradation, and regulatory pathways of all what you eat, carbohydrates, protein, fats. So basically, we divide these disorders to carbohydrate, to protein, metabolism, and lipid. So it is important to understand these facts that whether these cycle effects are anywhere, the urea cycle and the glycosylation, the lipid metabolism, it is the liver which is getting involved. And the other ones which we would like to talk about is the bile acid metabolism and peroxisomal, so the issues related with that, metal like copper or iron, the bilirubin metabolism, and now we talk a lot about the transport defect, just given a couple of examples, but lots to do. And then the respiratory chain, the drugs, toxin, oxidation defects, etc. That was just, so when do we suspect for a pediatrician, the message we always give is anybody who comes like the talk fatty liver or anything what we talk, if there was any family history, if there is a consanguinity, ethnic group, sibling death, developmental delay, growth retardation, failure to thrive, episodes of encephalopathy which was mistaken as seizure, or a failure which was early, the first thing that we need to suspect is a metabolic liver disease. And any patient, of course, we realize that glucose, it's the metabolism, you can get hypoglycemia, but unless proved otherwise, if you have a patient with hypoglycemia or lactic acidosis or hyperammonemia, then one of the first things that come in our mind is a metabolic liver disease. Geeta has talked about all these three things in liver failures. We understand at the end when everything conks off, you'll get it. But when you think the hyperammonemia is out of proportion, that's when I said that you need to think about a metabolic liver disease. Any patient who actually presents to you with unexplained hypotonia, and then there is an organomegaly or a dysmorphic features or a system more than one involved, just with the liver, there is some other system which gets involved, just like I said, hypotonia. So there's a neuromuscular system which is getting involved and steatosis in the liver. So this is what we always try to impress, that one should think about metabolic liver diseases. The purpose is we say that if you screen newborn 1,000 babies and you detect one hypothyroid, it was worth spending the money. Similarly, we mean to say that in metabolic, what we are justifying is that if you send one extra sample about ruling out, which is a treatable disorder, it's always pays in the benefit of the patient. And of course, when the coagulopathy in the first few months of life is out of proportion to the liver disease, like we see so many patients with biliary atresia, you don't see them with an iron ore of hanging around with 2. But if you see coagulopathy which seems out of proportion in the younger age group, then please do think about metabolic liver disease. Broadly, I would like to classify them with liver injury, without liver injury. With liver injury, only, liver is the brunt where it is, where only liver is involved, or with the liver other organs are involved, like Wilson. No liver injury where the problem lies only in the liver, like Crigler-Najjar, fatty acid, familial hypercholesterolemia. There is no liver injury, but yet the organ that is involved is the other, like MSUD, propionic acidemia. So these, it's not only the, for example, the enzyme is not only in the liver, but it is there either in the kidney or in the muscles. So that means the defect is there. There is no liver injury, but the enzyme should have been present outside. This is just a rough classification I made. So metabolic conditions with liver injury you can find anywhere and everywhere. These are all what we keep talking about, the carbohydrate, the protein, the fat, the transport, this is everything. We don't in India see alpha-1 antitrypsin despite load. So that is the last thing I would like to keep, but I put this image from the early 2 decades back, the way we had classified them into the other organs, etc. And this I've already explained how you can see the various causes like hemophilia, coagulation, all this. The defect is mainly expressed in the liver. So if you change the liver, that is in Crigler-Najjar or in primary hyperoxaluria, where the brunt is on the kidney in primary hyperoxaluria, but the defect is in the liver, so you need to change the liver. Similarly, urea cycle, you might find the brunt on the brain, but the defect is in that. Hypercholesteremia on the heart, but the problem is here. And the amyloidosis, also type 1, rare, but I've seen a kid and it's like really pretty bad prognosis that it can give it, where it goes multisystemic. So now this was the profile which was published from AIMS data in 2004. So they 15 years or 13 years of experience. They talked about the 159 cases, and that time they've talked about Wilson's number 1, and second was glycogen storage disorder, hereditary lipid. Now you will realize we were not seeing PFIC, so nowhere have they mentioned PFIC in that study. But now if I look into our profile that we analyzed, and so we had 572 patients over 2 decades, and in that again Wilson's is number 1, followed by the MASLD, which we've recently started seeing, and the PFIC, and then the tyrostemia, glycogen, small undiagnosed, and others. So coming to each a little bit, Wilson's disease, when do you need to transplant? Either there is a liver failure or decompensated end-stage liver disease, or when there is no response to chelation therapy, or when the child actually takes the chelation, stops it, and then comes back to you in an end-stage liver disease because the chelation was stopped. So these are the indications for liver transplantation. And we always say that if you have a Wilson's who has gone into encephalopathy presenting as liver failure, then the mortality is virtually 100%. So without encephalopathy, you may think about the indication, but if you have encephalopathy, you will not be able to cure it without a liver transplant. Tyrosinemia, what is the indication? We know we get NTBC, but if you do not, one slide is missing, if the patient is got, even on A, you cannot procure NTBC easily, B, even on NTBC, if you got adenoma or something where you're suspecting a liver cancer, or the patient has presented to you with liver failure. Now, PFIC we've been talking about, and I'm sure there is a topic on PFIC, you heard the whole thing, but there are patients who will either present to you with end-stage liver disease or with quality of life issues also, where you need to look for the response. And now, these are the 3 ones which we have been typically talking about, 1, 2, and 3, and the defect in the transferred proteins. But now we also like to classify the newer PFICs as defect in the canalicular, the trafficking of the ABC, the regulator of the bile acid, and the tight junction defect. So these are the other varieties that you're going to see in the transport, and we are not very clear about indications of transplant, but classically, these are the 2. The quality of life issues are now decreasing because we do have some new drugs which are there to reduce the itching part in the PFIC. So if there is no cirrhosis, you can go for a diversion. But if there is cirrhosis, then the diversion and the role is debatable. And we need to understand that the other organs are also involved. They could be PFIC 1, where you need to understand about the pancreas and diarrhea involvement, and also sometimes you may end up with a retransplant also in these patients. Now, talking about the organic acidemias, now what I would want to highlight is actually the incidence is 1 in 10,000, but I'm sure if we compile all the data, and Anupam was talking about yesterday, almost nearly 300, close to that, pediatric liver transplants are being done in India. But having said that, we don't do so much of acidemias, and the reason is they are diagnosed pretty late. And by the time the end stage, the brain is affected, and I was talking to Yacha, who was just talking about a child, MSUD, underwent a transplant, but maybe because it was late, his neurological status was not up to the mark. So it is a message that we need to give, is this organic acidemias that they have to be diagnosed by the enzyme testing and the genetic testing. And in MSUD, the problem is the enzyme is in the muscles. So there you eat it, your food is digested amino acids and it is there, but if this enzyme is defective, then in that case, you are storing, that is the classical, the leucine crosses the blood-brain barrier, it gives rise to cerebral edema and intracranial pressure. So imagine you need a special protein restricted diet. There's always a risk of neurological crisis even on a strict diet therapy when the patient gets unwell. So the cure is a liver transplant, but it is not an easy thing because you need an extremely geared up pediatric metabolic hepatology cream. We always wonder whether taking the parents may be right. So we've done around half a dozen of MSUDs, but we always prefer if we can have uncle and aunties available. So at least the first case that we did of this patient, 2009, and MSUD is liver, since the defect is not, the liver is not bad, you can give the liver to somebody else. So that's called domino, when you give the liver to someone else. And this was the youngest domino which we did it. And 15 years down the line, you can see he is eating a normal diet, doing well, and the other girl is now heading towards UK for her higher studies. And it's quite nice to see in metabolic liver diseases when you can cure them. So when we talk about the urea cycle disorders, there are so many of them, but I'm going to talk about citrullinemia. And there you need a very expert team in the anesthetist because they're going to get into crisis. The way you're going to be managing your lactates, the way you're going to be using your products, etc., is a different ball game. So even this is seen like 1 in 50,000. And the first transplant that we did in a citrullinemia boy was on the right side. He's like now more than 10 years and celebrating with a cake, which is not being seen. So they can eat a normal diet, and that really makes them. One child came to me late, but he was very unhappy because he was a Muslim child and he was never allowed to eat an egg or a chicken or anything in life. And he was very sure he wanted a transplant because it's like he wanted to eat what everybody else is eating. So that is what needs to be. So if you look at the split registry data, which comes from US, you will see urea cycle defects pretty high in them and cystic fibrosis. So you don't see these three in India. When we start talking about, I'll just start talking about Wilson's number one, and then whatever PFIC and tyrosinemia and GSD. But here you look, you have urea cycle, and so the detection is much earlier than us. And factor 7 or the other hemophilias we were talking, others people still don't do because you get factors, but factor 7 is pretty threatening when it is less than 1% because they bleed all over from everywhere, right in the brain, kidney, urine, stools. They're bleeding everywhere. So one of the first transplants we did was quite a decade back, and we didn't know what to do, but thanks to this tech machine, now you can do. So this baby was bleeding everywhere, including had intracranial bleed. So this was now, how many years? 14 years post-transplant. 2010 we did it. And so he's able to not go back for his but Chiari and protein CS deficiency, you need to be sure. If it is due to that, then it becomes metabolic. We've talked about hyperoxaluria, where the brunt is on the kidney, and unless I change the liver, kidney won't. And I believe in India, combined is better and cheaper rather than going for a sequential ones, which are more expensive. And we've done more than half a dozen of combined liver kidney transplants, right, starting from 2009, and these kids are now married and parents, fathers about them. So if I look into the data of nearly 500 transplants of them so this speaks that the metabolic liver disease is close to 35-37%. 1/3 of our patients are metabolic, and 1/3 of them present to you as liver failure, and 2/3 as chronic liver disease. And the outcome is better than the cholestatic liver disease if you see the overall outcome. And so that is our data, which we were presenting the structural liver disease, Wilson's, tyrosinemia, PFIC, allergens and protein and structural diseases. And the non-structural one where the citrullinemia, MSUD, PH1, Crigler-Najjar, hemochromatosis, etc. So the donors, you would either go in for the mother, father, grandparents. Having said that, one MSUD patient, we did take the mother and he's doing very well. Special arrangements you need, you can't just do it. You need sometimes BCA-free TPN, plasmapheresis, analysis, urine. The report should be within 2 hours, the text, the factor 7, the dialysis, the urine, all that, and the neurotherapy, which is GARE. Maybe we'll need less transplants when I get the gene, RNA, enzyme, chaperones, drug therapy, hepatocytes, stem cells. But right now you have liver transplant as the cure for metabolic liver disease with a very good outcome. And all that I would like to say is think about the diseases, and especially where the liver is not the brunt structural. That's when the diagnosis is coming late in India, and we need early diagnosis, early referral, and a multidisciplinary team and neonatal screening to identify. Now we know liver transplant program is developed, but doing metabolic liver disease, where the non-structural one is not very easy, and we need to respect each other who's doing those and increase their experience, because structural is easier than that. And the right timing is very important. I would like to thank all the residents who work round the clock with the youngest in the center, in the department. And I thank you all for trusting me, and it looks like 2.5 decades of liver transplantation and the journey. So many youngsters we've trained, 50 people all. And like Anupan and me were talking about, it's like more than 50 centers established. It's really heartening to see that everywhere you would find one of your fellows being there. Thank you so much.
Thank you very much for your excellent talk. I may know the experience of the other centers in the country which are published on metabolic disorders.
To the best of my knowledge, liver transplantation purely metabolic is not published. So I gave the data because we just started the publication on that, and now we have 120 patients of metabolic, and we are just publishing only India. And I was very particular, the data, the paper which we formulated is not on the international, because that would give rise to confusion, the follow-ups, etc. So I've taken metabolic liver disease in Indian children, and it's going to be when it sees the light of the day.
Number two, how can we diagnose more and more metabolic disorders which are required in this country? Maybe first top 5 we need to know. What are those top 5?
Yeah, that's what I was saying, that surprisingly what we are able to diagnose in the country is the structural one. The structural one is the Wilson's or the tyrosinemia, the PFIC, where the liver is getting problematic issues, and we are identifying. But the metabolic disorders, where you need a liver transplant to cure the metabolic disorder, as high as incidence 1 in 50,000, which are the urea cycle, the organic acidemias, which our country is not diagnosis, because we lack a robust screening program. So the end slide which I made, the way forward, is we need to improve on the screening, because now the genetic cost in India is, you can't believe it. It's like 10,000 even if you want to do a genome or a whole clinical genome and a whole exome, which is unbelievable that it came down. In the government sector, they give that rate. They don't give that for the private, which is fair enough. For the private, they give it 2.5 times the labs, and for the government, they give it half the price, which all of us have accepted it very graciously, but that is the key forward. The neonatologists have to be taught about this screening and early identification, and if they find a baby which is hypotonic, everything is not sepsis. All that these patients are done is sepsis, and by the time the parents come to you, they have neurological damage, because they are, and then it becomes a dharam sankat to transplant or not to transplant. I had a parent who wanted a child to be transplanted, a boy, but the boy was more than 1 year and like 3 months, like lying on the lap. I see no reason whether I would have been right to transplant that child, and I didn't really do it.
So what are the top 5 non-liver involved?
Yeah, so it is going to be, they took out mine, so the urea cycle disorders and organic acidemias. These are going to be as high in 1 in 50,000, 50, 57, Indian data. So these are the disorders where the awareness, and that's what I said, if you see the USA split registry, Wilson was not number 1. The others were number 1. And cystic fibrosis, and that was number 1. And in ours, Wilson was number 1, not only 2 decades back in the AIMS series, but also in our series. So we are still not reached that, and we have not even done less than a dozen of Indian patients with all these disorders, urea cycle. What has been done in the South Center is the one who came from Oman. So they are different, they picked up early, and so that's a different.
Okay, I think we'll go to the second.
Yeah, thank you
talk
so
of-
much. Thank you so much.
We'll go to the second talk of the session. The topic is diagnosis and management of progressive familial inheritance.
Sorry, I just missed that last slide. वो दिखाया नहीं था. Thank you की बात थी. We are doing the national conference 4th to 6th October in Delhi. It's going to be held in AIMS. I request you all, it's going to be very nice because the workshops that are there, we've got world authorities coming for the workshop. Nikhil Thapa for motility, Mike Thompson for endoscopy, and Peter for ultrasound, plus the at least more than a dozen international speakers. So we urge you to please attend the conference in Delhi with hospitality of all of us.
Only international speakers are important.
No, the speakers have been only the one who have done a lot of work in their field, because if they are called, they can't be just hi hello types.